Let's jump right into this explainer. We're running a highly focused clinical simulation today, locking down the strict diagnostic and management imperatives for 3 absolutely critical neuroendocrine GI tumors. No fluff, let's just get to the high-yield mechanics. Starting with the VIP-apoma peptide surge. Now, about 75% of these specific neuroendocrine tumors localize strictly to the pancreatic tail. What you're dealing with here is a highly malignant tumor just pumping out massive, entirely unregulated amounts of vasoactive intestinal peptide.
This completely drives a classic biochemical triad. VIP forces massive fluid and electrolyte secretion straight into the intestinal lumen. The result? Profound secretory watery diarrhea and a life-threatening hypokalemia. That's exactly why your patient presents with severe muscle cramps and profound weakness. But that's not all. Simultaneously, VIP actually inhibits gastrin, which leads to hypo or even complete achlorhydria, and it triggers this systemic facial flushing.
So, what's your definitive management mandate? First up, immediate IV volume and electrolyte replacement. That is absolutely critical, you have to resuscitate. Once they are stabilized, the definitive pharmacologic intervention is IV octreotide. That's going to halt those secretory kinetics and buy you time before potential surgical resection. And yes, that applies even if there's metastatic disease. Now you really want to pay close attention to this high contrast differential. VIP-oma versus factitious diarrhea from laxative abuse. VIP-oma gives you a secretory diarrhea with a low stool osmotic gap, we're talking under 50, and it persists even when the patient is fasting or waking up in the middle of the night. On the flip side, laxative abuse triggers an osmotic diarrhea. The gap there is well over 100, and if you do an endoscopy, you might spot melanosis coli, which is this dark brown colonic discoloration. Okay, let's put this to the test with a third-order presentation. You've got a patient presenting with profound muscle weakness, severe watery diarrhea that completely persists while fasting, facial flushing, and a critical potassium of just 2.2. Imaging shows a pancreatic tail mass. Their stool osmotic gap is 35. What is the most appropriate initial pharmacologic intervention? The trick here is rigorously analyzing these 5 distinct pharmacologic options against the exact secretory pathophysiologic mechanisms we just laid out. Your options are empiric fluoroquinolones, high-dose proton pump inhibitors, intravenous octreotide, loperamide, and pancreatic enzyme replacement.
Let's break down the rationale. Option 3, octreotide, is absolutely the correct answer. It definitively shuts down that VIP-driven secretion. Now, why are the others wrong? Well, empiric fluoroquinolones falsely assume an infectious etiology. High-dose PPIs target the acid hypersecretion you'd see in gastrinomas, which completely misses the fact that VIP-oma causes achlorhydria. Loperamide, completely inadequate for this kind of massive secretory volume. And pancreatic enzymes target exocrine insufficiency, not an endocrine peptide surge.
Moving right into Zollinger-Ellison syndrome and acid hypersecretion.
Let's see how ZES builds a totally different systemic destruction profile. A gastrinoma, which typically localizes to the duodenum or pancreas, drives this massive parietal cell hyperplasia. That creates an extreme gastric acid load, dropping the duodenal pH severely. And here is the malabsorptive trap you need to catch. That profound acid load permanently inactivates pancreatic enzymes right there in the small intestine. This directly precipitates severe malabsorption and steatorrhea. Notice the high-yield clinical variance here. VIP-oma diarrhea is purely secretory and features achlorhydria. But in stark contrast, ZES diarrhea is malabsorptive. It presents with steatorrhea because it's specifically driven by hyperchlorhydria. Also, you should suspect ZES immediately when you spot an absolute red flag, an ulcer unusually distal to the duodenum, like a jejunal ulcer. That is strictly pathognomonic.
Let's hit another integrated assessment. Your patient presents with intractable, gnawing abdominal pain, weight loss, and chronic diarrhea with visible oil droplets. An endoscopy reveals thickened gastric folds and multiple refractory jejunal ulcers. So what is the definitive diagnostic mandate?
You need to evaluate these 5 diagnostic modalities strictly based on that suspected gastrin-driven destruction: stool osmotic gap calculation, fasting serum gastrin and secretin stimulation test, 24-hour urinary 5-HIA, anti-tissue transglutaminase IgA, or serum VIP levels. Breaking this down, option 2 is exactly your correct diagnostic mandate. A fasting gastrin greater than 1,000 is overtly diagnostic, and if it happens to be indeterminate, the secretin stimulation test will confirm it. The other options totally fail here. Stool osmotic gap won't localize a hypersecretory lesion. 5-HIAA is a screen for carcinoid.
Anti-TTG-IgA screens for celiac disease, which, remember, lacks refractory ulcers. And serum VIP? That's targeting the entirely wrong neuroendocrine axis.
Shifting into our final module, carcinoid syndrome and tryptophan depletion.
Let's map out this systemic serotonin cascade. A classic carcinoid tumor, which usually originates in the ileum or appendix, actually has to evade hepatic first-pass metabolism to cause systemic symptoms. Practically speaking, that means it has metastasized, typically straight to the liver. Once it's there, boom, you get a massive systemic serotonin surge. The tumor just aggressively shunts the amino acid tryptophan to synthesize all that serotonin. The big problem? This severely depletes the substrate required to make niacin, which is vitamin B3.
This sets up a perfect clinical variant scenario. Sure, both carcinoid and VIPoma can give you episodic flushing and secretory diarrhea, but carcinoid is strictly accompanied by wheezing and right-sided cardiac valvular lesions like tricuspid regurgitation. VIPoma totally lacks those, presenting instead with that profound hypokalemia we talked about. You also want to contrast this with rosacea. Rosacea flushing is localized just to the central face, whereas carcinoid flushing is systemic.
All right, this demanding vignette really requires your immediate recognition. A patient reports episodic systemic cutaneous flushing, abdominal cramps, severe persistent diarrhea, and wheezing. Your exam shows a new pansystolic murmur that increases with inspiration, plus a scaly rash on sun-exposed skin. What is the most appropriate initial diagnostic test? You need to select the absolute precise diagnostic mandate from these 5 high-noise options: an echocardiogram, a 24-hour urinary 5-HIAA assay, fasting serum VIP levels, a secretin stimulation test, or a stool assay for C. diff. Exhaustive analysis proves option 2. The 24-hour urinary 5-HIAA assay is without a doubt the best initial diagnostic test for carcinoid syndrome. Now, while an echocardiogram is great for evaluating that valvular lesion, it's not going to diagnose the underlying neuroendocrine tumor. Options 3 and 4 target VIPoma and ZES respectively, but those lack the right-sided murmur and wheezing. And a C. diff assay just completely misses the systemic neuroendocrine presentation.
We're concluding with this definitive clinical mandate. That scaly rash we saw in our patient, not coincidental at all. That aggressive tumoral tryptophan shunting directly precipitates pellagra. It presents with that classic triad you've got to memorize: dermatitis, diarrhea, and dementia, all strictly due to severe niacin deficiency. Master these distinct neuroendocrine pathways, isolate their specific markers, and anticipate these biochemical traps to guarantee absolute diagnostic precision.